Assalamu alaikum and good day, everybody. I'll be presenting today research that we had done in our center titled Safety and Efficacy of Different Basal Insulin in Type 2 Diabetes mellitus with Chronic Kidney Disease in Ramadan. I would like to acknowledge that this is the work of my postgraduate student, Dr. Nur Hazika binti Baharum, and as part of the team study. Right. So as an introduction, as you know, a lot of patients type 2 diabetes with CKD, some of them are exempted from fasting because of the risk that they pose in terms of hypoglycemia and other complications. However, we also know it has been shown in the literature that the incidence of hypoglycemia in fasting is increased particularly in insulin-treated patients and also those with advanced CKD. Fasting and CKD are also associated with wide fluctuations of blood glucose, and this is translated into this terminology called unstable glycemic variability, which is known to be a predictor of hypoglycemic events, independently contribute to diabetes-related complications. And furthermore, patients with CKD are known to be vulnerable to high glycemic variability. And so, therefore, insulin analogs have been known to replace human insulin due to lower risk of hypoglycemia and postprandial hyperglycemia. However, there's limited data on safety and efficacy of the different types of basal insulin, both human and also human insulin or analogs, especially in diabetic kidney disease population. So thus, this study that I'm going to present to you had a primary objective, which was to evaluate the safety of the different basal insulin. In this study, we looked at the different types, including insulatard, levemir, and glargine, and we looked at particularly on the hypoglycemic profile, defined by the outcome of low glucose event, LGE, and time below range, TBR. And also we looked at the glycemic variability and the change in renal profile post-Ramadan. We also looked at the efficacy of the different basal insulin through the changes in HbA1c, fasting plasma glucose, and also anthropometric measurements post-Ramadan. The secondary objective was to look at a categorical outcome in terms of the high glycemic variability defined by CV of more than or equals to 36% in this study population. So just to give a background of it, this is an open label prospective observational study, a single center study with convenient sampling. We looked at the patients throughout the period of March 2022 to May 2022 throughout the Ramadan period of that year, and the sample size was calculated to have approximately 18 patients per group with a total sample size of 54. These were our inclusion and exclusion criteria, quite standard. Patients with type 2 diabetes above the age of 18, with HbA1c between 6.5 to 10%, who had been receiving this basal insulin, as I had mentioned earlier, at least a minimum of 8 weeks prior to Ramadan, and they had intended to fast for more than 15 years. We excluded type 1 diabetes, CKD stage 4 and 5. We only included those stage below 3 and below. And those were within the very high risk base on the International Diabetes Federation and Diabetes and Ramadan International Alliance guideline. We excluded those as well, and the other various exclusion criteria as listed here. So in terms of the study flow, just very briefly, we screened patients based on the calculator, the IDF-DAR calculator, as I mentioned earlier. And those who met the inclusion and did not meet the exclusion criteria were randomized, informed consent was obtained, and there was seen at least a minimum of 8 weeks pre-Ramadan at the first clinic visit, where all the measurements were done. 2 weeks before Ramadan, they were seen again, and they were given this Freestyle Libre, which is a glucometer, continuous glucometer, for a regular glucose monitoring. And this was given to them for free, and they're required to make the measurements as instructed. And then at 2 weeks post-Ramadan, they came back to the clinic with all these anthropometric measurements were done, and blood again was taken. And then we obtained the readings from the glucometers as shown here, to obtain all the outcomes as I had outlined previously. So what we looked at particularly were the low glucose event, which is defined as glucose below the target range for at least 15 minutes or more in duration. We looked at time in range, TIR, which is the percentage of time of blood glucose levels between 4 to 10 millimoles per liter, time above range, percentage of time whereby the blood glucose level is above 10 millimoles per liter, time below range, TBR, percentage of time blood glucose remains below 4 millimoles per liter, and as I mentioned earlier was glycemic variability, which is essentially the measurement of degree of fluctuations of glucose readings over a given time, and CV of more than 36% is considered as unstable or unoptimal glucose level. So these were the readings that we obtained from the meter, and you can easily identify the number of glucose events. It also gave us the reading of the glucose variability as seen here at the lower bottom of the screen as an example here. And the time in ranges are also obtained within the software of the results given. Of note, all patients were also told to break their fast when the sugar level drops to below 3.9 or increases above 16.7, or with symptoms of hypoglycemia or any acute illness were to occur. So therefore, I'm going to go through the results now. And this is the baseline demographic and patient characteristics. It was quite interesting to note that these are quite elderly patients with mean age of 66, between 57 to 66 years old. That is median, sorry. Predominantly more males, and with a duration diabetes of more than 15 years, as you can see here, with BMI of almost 30 kilograms per meter squared. And in terms of the CKD, they're CKD stage 2 and 3 mainly, with a mean HbA1c or median HbA1c of approximately 8.1 of around thereabouts, and with fasting sugar of between 6.8 to 7.7. Baseline demographic also were very similar in terms of the creatinine, the eGFR, and the medications that they were using. As you can see, there was no significant differences in the populations of the three groups. Right, so in terms of the risk level as well, most of them were on the moderate or high risk, despite that they insisted on fasting with the prandial insulin and basal insulin very similar within the three groups. The total insulin also no significant difference between the three groups. Right. So in terms of the result of the low glucose event and glucose distribution profile, we demonstrated similar events between the three groups, insulintype, levemir, and glargine. However, just of note, the numbers numerically were very, very similar as well, other than perhaps for me to highlight the glucose time below range, TBR, in terms of percentage for levemir is, numerically much lower. It's half of the number demonstrated by the insulintype group. However, this was again not statistically significant. And in terms of glucose time in range, TIR, and proportion of pre-iftar hypoglycemia, again, no significant, statistically significant difference, but just bearing in mind that the number numerically seems to be quite low in the levemir group. All right, so for the main objective in terms of glycemic variability, we demonstrated similar numbers between the three groups, but perhaps there might be a trend towards higher glycemic variability in the insulintype group and being lowest in the levemir group. So in terms of the unstable variability, again, insulintype group maybe perhaps could be higher, but although it is currently in the with no statistical significance. In terms of changes in HbA1c, fasting plasma glucose, creatinine, and eGFR, again, the three groups did not demonstrate any significant difference. However, of note, we would also like to highlight that there were reductions. There seemed to be reductions in the HbA1c, perhaps not much changes in the levemir, the fasting sugar. However, the fasting sugar looked like it increases a little bit within the three groups, and however, again, no significant difference. The plasma, creatinine, and eGFR were very quite stable throughout the study duration. Right. In terms of body weight, we demonstrated some changes, significant changes within insulintype group. As you can see here, a slight reduction in terms of body weight of almost 1 kilogram, which is reflected in the BMI and the waist circumference. In the levemir group, we only saw a significant difference in terms of waist circumference. However, these changes intergroup changes were not significantly different. Right. So we also did some multivariate analysis, and we identified that some clinical predictors for the high glycemic variability, again defined as CV more than 36% among the study population. Sorry, apologize for that. So there's some factors that we identified as duration of diabetes, blood pressure, BMI, and treatment of sulfonylurea and novorapid. Also looked at baseline creatinine. So but these are not statistically significant. So other than the expected glucose distribution, glucose time in range, and glucose time below range, so which is obviously reflecting glycemic variability. In terms of clinical predictors, finally, we identified that higher number of low glucose events was associated with a 1.29-fold increase in probability of high glycemic variability, which really makes clinical sense, and higher percentage of time spent within range CIR contribute to 0.9-fold reduced probability of high glycemic variability. So in terms of discussion, just going through the results that I presented to you, all three basal insulin reported hypoglycemia in Ramadan fasting. However, these numbers are actually quite small. There was no significant difference in hypoglycemic events in terms of TBR and LGE between three basal insulin. And this seems perhaps to be not so similar to the previous studies by Hassanin et al. In 2020, who reported incidence of severe or symptomatic documented hypoglycemia in those using glargine. Peugeot 300 was low and similar in pre-Ramadan and Ramadan. And also by Kaplan 2022, that the percentage of hypoglycemia was higher in glargine than in levemir. So we did not demonstrate a similar, but although numerically it might be reflecting some similarity as well. In terms of the glycemic variability, I must emphasize here that glycemic variability has not been used very much in Ramadan, so therefore we had no published data to compare with. However, and the result that we observed was a low glucose event was found to be the predictor for high glycemic variability, making it emphasizing the need for perhaps identifying these hypoglycemic events to avoid high glycemic variability. Time in range was associated with less glycemic variability, and we would like to quote Gomez 2020 et al. 2021, which stated that within the non-fasting state, so in our study was a Ramadan study, so compared to Gomez, which is non-fasting state, eGFR of less than 45, HbA1c of more than 9%, and history of hypoglycemic events were indeed predictors of high GV. So perhaps this was the basis of the need for studying the safety in terms of glycemic variability in Ramadan as well. In terms of the changes in renal function, they were not statistically significant within the three groups. And we would like to also to note that there's no published data on renal outcome on the respective basal insulin, and the renal function among CKD stage 3 showed no significant change due to fasting, but that was demonstrated by Alawadi et al. In 2019. And eGFR also did not change significantly after 4 weeks of fasting and remained insignificant 4 weeks later at the end of fasting, which is showed by Hassan et al. In 2018. So our study seems to concur with current literature. In terms of changes in HbA1c and changes in glycemic control, the changes in HbA1c pre to post Ramadan was not significant when comparing between the three groups. There was no published data for insulitat and levemir. However, we concur with Hassan et al. In 2020 that showed glargine 300 treated patients showed a reduction in HbA1c from pre-Ramadan 8.1 to post-Ramadan 7.6. In terms of numerically, however, we were not able to demonstrate that statistically. In terms of changes in anthropometric measurement, insulitat showed a significant small reduction in weight, BMI, and waist circumference. We had no current literature to compare this with. We would like to extrapolate that the hyperglycemia-induced osmotic diuresis might have resulted in some fluid loss and subsequent weight loss. Levemir, however, showed a significant reduction in waist circumference only, but no reduction in weight and BMI, and we were perhaps not able to offer a similar explanation to this because there's no published data also in Ramadan. So in conclusion, our study demonstrated that insulatard levomeringlagen demonstrated similar safety and efficacy among patients with type 2 diabetes and CKD who fasted in the month of Ramadan. And perhaps our study showed that there is a role for measuring glycemic variability to reduce risk of hypoglycemia or hyperglycemia in Ramadan. Finally, I would like to take this opportunity to thank my team, particularly Dr. Hazika for conducting this study and the whole team for helping out. Thank you very much.